I am here to welcome Dr. Deb Willis, who received her PhD at the University of Michigan in the doctoral program in social work and sociology. Her interests include child welfare policy development and program evaluation. Dr. Willis is currently the Director of Programs at the Guidance Center and the Center for Excellence program there as well. She supervises all individual program directors, research, and training at the agency. Dr. Willis is involved in many committees and task forces, including the Wayne County Systems of Care and our own Virtual Center of Excellence. Additionally, she is an adjunct professor at the University of Michigan School of Social Work. Please join me in giving a warm welcome to Dr. Deb Willis.
Thanks. Okay. I'm not used to standing still, so I have this in case I can't stand it. I'll start out this way. First of all, if you have any questions, stop me and ask them. I will stop at the end of the presentation and take them in a more organized way, but sometimes it's better to ask while you're thinking of it than to go on and then it comes up out of context. So having said that, I'm just going to get started. This is a hard topic to talk about to practitioners, mostly because really all I'm going to end up being on some level here is an info commercial pushing the use of evidence-based practice and helping you to understand what it really does involve and what I'm hoping to make you a better consumer of it and maybe even turn you into an advocate for it. And so we'll see how well I do with this. But basically, just so, you need a context for where I'm sorry, Brett, I'm not talking directly, am I? I can't do it. I have to do this. Just so you know, I've been a clinician. I did it for 10 years in New York. I also did some work with sexually abused children for about 6 years. So I do understand being in a clinical setting and getting asked to do things that don't seem to make a whole lot of sense at first, anyway. So I am coming from that kind of an arena. I do understand how that works. I'm also coming from the point of view of being on the other side, walking into an agency and hoping that I can do some training and then evaluate the results of that training. So I've kind of been in both places, and I'm hoping that's going to help us as we go on with this. There's too many things to shuffle. This is not... Okay, let's see if I can do this here. Okay, first of all, there's a misunderstanding about what evidence-based practice is. We use the term to refer to an intervention or a treatment when in reality, it's really, truly, honestly, a practice. It's the way you're supposed to do your job. And actually, it's the way most of you do your job, you just don't know it. So basically, the informal definition is the one that is probably the most useful here. It's the actual use of practice-related research in making clinical decisions. That's all it is. It's taking something that's been researched in some way, shape, or form, thinking about it, looking at the situation that you're in, and making a decision to use it or not use it. That's it. You do it every single day. How many of you are clinicians, therapists, work in the therapy part of the world? Okay, case managers. We got case managers here. Nurses, anybody nurses or... do we have direct care staff who are working out? Okay, we got some of you. Every single time you make a decision, every single time, you've gone through a process in your head that takes in information, looks at it, analyzes it, and that decision comes out based on it. So you do this every single day, no matter what part of the mental health area or arena that you work in. All that I'm going to talk about for the rest of the time I talk is going to be how you take that out of your head and make it more visible. That's all evidence-based practice really is. It's taking the decision-making process that you use already, making it visible, and getting it to the point where you can test whether or not what you think is going to happen actually did. Okay? It's just the trouble with research and the trouble with academics who come to help train you in these things is they speak a different language than you do. And that's all it really is a different language. It's really not some mysterious thing out here. How many of you had to take a research course at some point in your training? You know, okay, a lot of you did. Remember how that, I remember when I first walked into that research class, I was scared to death. It probably had something to do with math. I was no good at math, and now I was in a lot of trouble. Well, it turns out that a lot of what we do as social workers, it doesn't really involve math, but it does involve a different language when we start to talk about doing evidence-based practice and paying attention to the pieces of evidence that we're going to end up looking at here. Okay, so how does it really work? And again, all I'm doing is taking what you do and putting it into making it visible. So how does this work? It means that as a practitioner, you have to be self-consciously problem-focused. And all that really means is you have a client that comes in with a specific problem, and you're going to turn that problem into a question. And you do this automatically. Some of the questions we'll talk about in a minute, but you're automatically going to focus on a problem. And again, it's what you do every day in your practice anyway. You're going to integrate information based on your own experience, based on what others are telling you, and based on what you've read, maybe on other factors that I can't even think of right now, but you're going to gather this information and you're going to integrate it into your decision-making process in order to solve the problem. Evidence-based practice also includes practitioners being effective, efficient, and humane in terms of how you address clients' needs. And these are important concepts. Most of the time, people think that to be effective doesn't necessarily go with being efficient, but that's not true. Those two things can go together, and if we're going to really do this evidence-based practice technique and make it visible, we really need to do both of those things. That means that you're going to have to be measuring your outcomes in order to tell whether or not you are being effective. You're going to need to do your jobs efficiently. It doesn't do us a whole lot of good well, let me give you the example in the juvenile justice field. We know an awful lot about kids who are in juvenile justice. We know, for example, that if you take a child who's been in trouble with the law, the thing that you want to do is surround them with services. You want to pay attention to them, know what they're doing at all times, because we know that one of the major reasons that stops kids from getting into trouble further is maturation. They actually grow up. And most of the kids, once they grow up, they quit being squirrely. That's a technical term that I use to describe delinquency. And the best way, the very best way of making sure that they stay away from committing additional crimes would be to take the kid and handcuff them to an adult for about 5 years. They couldn't do anything, they'd grow, and then when they turn 21, let them go, and they've grown up and they're fine now. But that is so inefficient, that won't work. So we think of all these other ways that we can do this in order to make sure that our practice ends up being efficient. And then, of course, we have to be humane. It would not be fun to stay handcuffed to an adult for 5 years. for most kids. Not for the adult either. I don't think that's a fair thing either. The other part of evidence-based practice that's important for you to remember is this is supposed to be a learning curve. It's supposed to be a learning environment. You're supposed to try things, learn from them, and then do them again in a slightly different way based on what you've learned. I hope you're getting a different picture than I think the picture that we often have in our heads about what evidence-based practice is. It is not somebody coming into your agency, teaching you how to do something, and then leaving. It's you getting information, taking it in, analyzing it, and using it based on who you are, the environment out of which you're operating, the needs of the clients, your own maturation. All of those things have to be part of evidence-based practice, and it really is our responsibility to understand that and see it that way. And I think probably there's not very many people that I know who work in this field who don't do that. We just don't recognize it always, that we're already there. Okay, this stage is wobbly. Do we have insurance in case something happens? Let's just make sure. Okay, I said that the main thing that you're going to need to do here is set up the problem. I mean, that's how evidence-based practice works. You're trying to solve these problems that come at you every day. And so what you do is you take the information that you know about the clients and you turn them into questions that you're trying to find answers to. And things like, what would work best in this situation? Given what the client wants, which is often very different than what we know in our own hearts the client needs, based on what they want, how in the world is there something somebody else has done out there that's going to make a difference? You also want to look at what have other people tried. And there's lots of ways to find this out. Of course, the best way is that you get, let's say, half a day every week just to go surfing on the web and look up articles. But that's not going to happen. So how do you find these things out? Some of it is trainings like this. Hopefully people are giving you resources, and maybe you'll look one or two of them up now and then. Also trainings in what does work, and there's lots of websites. I gave you some examples in your packet of places you can go to look for different kinds of approaches. But basically, you're going to kind of need to show the initiative to seek some of this stuff out. I think one of the other problems with evidence-based practice is we've gotten out of the habit of knowing that it really is our responsibility as clinicians to really be doing this kind of work, and we're kind of passive. So what ends up happening is we get told by our supervisor that somebody's coming in a couple weeks and they're going to train us in the latest way of intervening in a particular kind of client's life. And so we figure out what our schedule's going to be, everything gets rearranged, and we go and get the training. What I'm suggesting to you is that based on your own needs as a practitioner, I'm hoping that maybe you'll see that being proactive about this might be a better way to go. Maybe you can help identify some of the directions that you think need to be gone in terms of your own training. It always kind of takes the wind out of my sails when someone says, I need training in this, and here's why. I don't quite know what to do with that, but give them the training. It's kind of scary. Okay. Okay, Kevin, here it goes. You can leave the room now if you want to. The best example I have of how this might work, one of the staff who works at the guidance center came across, I don't know what he was doing, I'm sure it was on his own time, of an example of a measure that you could use to look at your own practice, to see whether or not you were having an effect. It was a way of working with parents and kids. He was a child therapist in helping them to be involved in the process of looking at their own change. And we were using the Achenbach. Any of you know what that is? It's an assessment that you use with kids to look at behavioral changes over time and where they are in terms of their behavior. And he didn't really like the Achenbach that much. And so what he was proposing is, since we were using the CAFAS anyway, could we go to this other method where he would do this use the kids and the parents to measure their own progress, and he would use it as a discussion event with them to help move them along. And he brought articles with him. Now, here's a practitioner who's got, years of experience showing up and wanting to do more work. What could we do? We said, of course. We made him a hero. We showed him as an example to everyone. People hated him for a little while, and then they moved on. And we put it into play to see exactly what would happen. And there were all kinds of unanticipated consequences of it. We measured it to see whether it was having the effect it was supposed to. And we're still following it. And I think it was a good thing. I could be wrong, but it did what it was supposed to. And some of the unanticipated consequences that went with it were kind of fun. Like Kevin noticed that he was paying more attention to parents than he had before. And we were also able to see this big difference between the children and the parents in assessing whether they were getting better. Children often thought they were better before parents did. And so it helped give him more information than he'd had before. And that's what evidence-based practice should be. The clinician taking some of this responsibility. There should be a dialogue and an ability to use things to help make your practice more productive. Okay. We also need to have opportunities to examine critically what other people have done. So far you notice I haven't really talked about, never mind, I won't tell you what I haven't talked about, I'll just keep talking, that'll work. You need to look at what other people have found to be effective. And you do that in supervision, you do it in case conferencing, you do it when you read another article, as I said, you do it when you come to trainings like this, and you automatically incorporate those things into your own practice. Somebody gives you a tip, and you take it and you use it. And you automatically are evaluating it, and its worth. You're automatically evaluating it, because the next time you use it, you've probably tweaked it just a little tiny bit. And you're constantly doing that as part of your process. The other thing you do without even thinking is you automatically change what you're doing to fit your conditions. That's part of doing good practice. It's taking what you know to work in one situation and being able to use it in another in a slightly different way. And you have to be able to do that too, or it won't work. The people who developed the notion of evidence-based practice were our friends in the medical profession. And it's really easy in the medical profession, right? You develop a technique, the patient either lives or they dies. If they live, you did it right. If they die, you didn't. It's pretty simple. So here's an example. A lot of you probably had first aid training, and you know that when someone has a wound, direct pressure, right? That's the ticket, direct pressure. We put our hand right on there and we stop the blood, and that's the way it's supposed to work. But the theory of applying direct pressure the way you do that, the way you apply it, is going to change depending on the condition. I mean, it has to. So if somebody got something going on, they're bleeding and it's their leg, you might be able to get your hand around them. But if it's their shoulder, you have to apply it in a little bit of a different way. You have to be able to take the understanding of direct pressure, and use it in different situations depending on what's going on. It doesn't change the fact that you're applying direct pressure, but the conditions change, and you need to be able to do that as a practitioner. Okay. You also have to fit the treatment that you're using to the needs of the consumer, and you have to test whether or not the outcome that you're hoping to achieve actually occurs. And again, I think you do that. I think you do it, you just don't do it consciously. And that's what we really need to do more of, is to make these things conscious rather than just happening. Okay. No questions, so I'm either really clear or you already knew all this and you don't have any questions, or the info commercial's going very well. I'm not sure what yet. We'll find out. Okay. Evidence-based practice is how you use information. So what is that training that you end up having to take? It's really not evidence-based practice. It is an evidence-based practice with a small p, perhaps, but a better way of naming it would be to call it an evidence-based treatment or an evidence-based intervention. And what we're going to talk about now is exactly what is it? What does that mean? What is an evidence-based treatment or intervention, and how does it fit into your being able to do good evidence-based practice? Okay, EBTs are treatments, or they're interventions, or they're, I don't know what else to call them. They've been evaluated in a formal kind of way. And that formality has included the use of sound scientific methodology. Those are the things that only people like me are trained to do. You can never do them. I don't even know why you try. That's not true, by the way. That EBTs are things that have actually been tested on real people. They aren't just the theory of how something might work. They've actually been tested. And they've resulted in outcomes that are going to happen again and again and again. Okay, we have a lot of confidence in these findings or results. They're consistent, and they've been found to be consistent across more than one trial. Okay? That's all an evidence-based treatment really is. It's a theory that's been tested, and it's been tested and found to be consistent in terms of the outcomes. The outcomes also have to be able to be found and present across more than one kind of research setting. Okay, what that means is you might be, if you go to, let's go back, you have a practice that you're trying out, a theory that you want to test, and you do it in your agency. And your agency is made up of children between the ages of 6 and 12, and they have certain sets of characteristics and certain diagnoses. All those things are present, and you think that this will work with older kids as well. You're not sure, but you think it will. So your friend, who also is eager to be seen as a hero the way Kevin was, tries it out in his agency, and sure enough, it works for that age group as well. And that age group had totally different characteristics, and we still got the same results. Now we're starting to gather evidence not only that shows us this intervention works, but we're also starting to understand who it works with and how big of an impact can we expect it to have. So this evidence-based treatment or intervention that somebody's going to show up and want you to learn how to do, I mean, you can see the reason why they want you, why we should want to use it ourselves, and why it's something that makes sense for us to use. It has outcomes. We know if we use this with a certain group of people, we're going to get outcomes that are measurable and that are real. And that's the push for this. And we have to get over our angst about outcomes. We just have to let it go and embrace the need to measure the results of what we're doing. Okay, so that's part of my message here, and I'm hoping that we'll be able to talk a little bit about how do you do that, how do you get over that. The reality here is that depending on how long you've been doing this work, you have results, you have outcomes. You know that you have them. What we haven't done and what you haven't done in your own individual practices, and what I didn't do when I was doing it, you haven't taken apart exactly what it is you're doing. There's this black box. You go inside your office and the door closes, and we're not sure what you do in there. But when they come out, when the consumer comes out, they've been changed, right? I mean, that's how you do have outcomes. You have an impact. Behaviors change. Children start showing up for school. They start making friends. They aren't hiding in their room. Parents aren't pulling their hair out anymore. All these things happen. There are outcomes. CAFIS scores change, right? All these things happen. But what you did in that room with the door closed, I don't know. It must have worked, though, because here we got coming out some outcomes. So part of the treatments that you're being trained on, part of this training includes being able to measure what you did. Not just what the outcome was, but how you got that outcome. And if you could only go in the room and close the door and write down every single thing you did, maybe we'd know. And then you could have invented an evidence-based treatment, and everybody would use it and be trained on it, and you'd all be rich and you'd be able to retire. It's a good way to think. Okay, so we have these evidence-based treatments, and we need to look at the outcomes of them. Where am I? So how do we get this evidence? How does this work? Okay, here we're going to get into this language that makes everybody's eyes glaze over and everyone fall asleep and want to leave the room. But we're going to do it anyway. Evidence comes in many forms. The gold standard, the one that makes every single academic researcher salivate and jump up and down for joy, is the ability to do a randomized controlled trial. That's the fun one, right? It's where you got a group of kids who have a certain problem, and half of them randomly get assigned to group A or group B. And the reason that we do those kinds of things is if you have a group and they all have the same chance of ending up in group A or group B, then the only difference between those two groups is that one got A and one got B. And that helps us to be very, very sure, well, not very, very, nope, whoops, sorry, I lost my head there for a minute. It helps us to be sure, more sure that the actual intervention that we're testing was the reason that we got the result that we did. That's why this is so important. It makes logical sense if you think about it. If I'll just keep using Kevin since he's convenient, and I won't forget his name because I've said it out loud once. If Kevin and I have the same problem, and Kevin gets one treatment and I get the other, and there's really no difference between Kevin and I because gender doesn't matter in this particular problem, and Kevin gets a different result than the one I get, then the only reason for that result, the only reason that makes any sense anyway, is that he got a different treatment than I did. Okay, and that's why these randomized controlled trials are so important in helping to build this evidence chain. Once that happens, we have a better a more thorough understanding of what this particular intervention can actually do. Okay, so how do we know? We put these people in these different groups. One time I was working in this office, and the people down the hall were doing this, and we kept the book. They weren't allowed to look at the book, but every time they got a new client, they'd come down, and we'd open the book and go, treatment A. And then they'd go away. And then another person would come down and we'd look at the book, treatment B. Because they weren't allowed to know what was going to happen. They weren't allowed to, in any way, influence which group people got assigned to. And we were the keepers of who got into what group. You can see differences. Suppose Kevin's CAFAS score at the end of the intervention that he's involved in, he goes down 80 points, and his CAFAS score is now 20. And my CAFAS score only goes down 20 points, and it's now, 100, I don't know, whatever it is. But it's only down 20 points, okay? There's a difference, we can see it. But, there's only 2 of us in this study. So this might be just kind of arbitrary. It might be something that just happened by chance. It might not be a real difference. And so the other piece of information, and I'm telling you this for a reason, which I'll make clear in a minute. The other piece of information that researchers use to help us know whether or not this treatment has some kind of impact, they use that term that you've heard, the significance level, looking at whether or not the results are significant or not. Remember, you see that sometimes in articles. And again, this is one of those things where researchers jump up and down with joy when they hear about results that are the ones they're looking for. So basically, a randomized controlled trial where you can really put people into groups arbitrarily and then be able to have enough people in the study to be able to do a statistical analysis to determine what are the chances that the results that we got happened by accident. That's what that measure is all about. All it's looking at is what are the chances that the results we got happened by accident. And what they're looking for is they want the odds or the chances of that happening by accident to be less than 5%. Somebody made that up. If the odds of something happening by accident are less than 5%, we're a lot more confident that the reason that change happened is due to the intervention. Okay? Everybody got that? There's going to be a test, and I'm going to ask you to repeat it. So if someone tells you they did a randomized controlled study and they found out that the difference in the results for the 2 groups was present, that there was a big difference in their CAFAS scores, but they tell you that the odds of that difference happening by chance were 7%, you're going to go wisely, oh, too bad. Those odds are too high. There's too much of a chance there that there's 7% chance that that difference happened by accident. I just can't accept those odds, and we must try again. And that's what they're looking for. They're looking for something that ends up happening with a very low chance of it being an accident. Those are the 2 pieces you need to get out of this part that I'm talking about now. When somebody comes to you and says, we have an evidence-based treatment, and SAMHSA has said so, that it's a very good chance that it's been tested in randomized controlled trials and that the differences found in those trials have been statistically significant. And that's why everybody's excited about it, and that's why they're calling it an evidence-based treatment. Do you see how that's different from your evidence-based practice that you do every day? You're doing it based on your own experience, It's not any less valid. If you had been keeping track of this and talking to people about it all the time, we probably would have enough cases to be able to determine whether your results were statistically significant too. Except we don't know what you do behind that closed door. So if you'd done that too and written it all down, we'd be able to connect what you do to the results as well. But you don't have time to do that. You just are using your gut and your colleagues and things you read and trainings like this to help you decide what to use. You can also use information that others have gathered that have these components in them, this gold standard. So this is just, the rest of this list is just other ways that evidence is given to you. The gold standard, and then all the rest that don't really matter, that no one counts, except you and me. So surveillance data, that's just kind of noticing differences, and you're looking at a group of kids and you're looking and you're noticing that there are differences among them. You're seeing it. Sometimes you can go and you can do, people do these things called, I'm not even going to go there. There's systematic reviews of multiple intervention research studies. Somebody took an article and they summarized all the research that's out there about something. That's a nice thing to have because it really gives you the overview of what everybody's found. Expert opinion or narrative reviews, that's when you come to me and you ask me, what do I think you ought to do? And I'm an expert, so I tell you. Sometimes without you even asking me. A single intervention research study. That's the thing that some of you learned when you were in graduate school or in undergraduate school, where you take one case and you do a pre and a post and you measure the results. You can do that as well. A program evaluation, we get those all the time. Word of mouth, the media, marketing, personal experience, those are all valid ways of collecting evidence. All of them. The one that we use, that we pay money for to get trained in, however, usually comes from that first one. But the rest of them are also good things as well. Okay, again, anytime you have a question. Oh, good, Kevin. This is Kevin, everyone. I forgot, I wasn't going to say that, was I? Okay, speak up, Kevin. Apparently, Kevin, you have too much time on your hands, and you're reading beyond your, you know, the best, remember, of course, the best of all possible worlds, they would exactly be measured against treatment that also can be spelled out and standardized. But we don't, I mean, a lot of times, the perfect research condition that gets researchers all crazy never exists in the real world. You just can't do it. So generally speaking, these randomized controlled trials, or RCTs, see, just learn the language and you sound real smart, and the researchers will listen to you when you use that language. But mostly what they're doing is they're training you in CBT, okay, which has, you know, a manual to it, and you practice it and you learn how to use it, measured against treatment as usual. Go in the room and close the door. And so all we know is that the results of CBT appear to be better than the results of treatment as usual. But we don't know what treatment as usual means. We don't necessarily know, because again, you're inside that closed door and you didn't write it down, all these things. So you're right, it is a criticism. It's a valid criticism, but you have to remember that the more we do study these things over time, the more evidence we get, and the more sure we are about what we're finding, and we'll start to make people write things down eventually. Somebody will get some money to do that at some point. Maybe when, never mind. Okay. It's never perfect. I wish it was perfect. Everybody wishes it was, but, well, you might not wish it's perfect. It would be fun to actually be on a study that could be perfect. But I have found in my life that people aren't like that. People are never the way you want them to be in these studies. Okay. This is, according to researchers, how it's supposed to work. So this is when I'm working at the School of Social Work at Wayne State University, and I've shown up 2 weeks after your supervisor said I would to train you in CBT. And this is how I think it's going to play out. I'm going to be able to produce research that empirically demonstrates what strategies work. That's my main goal in life. I want to collect enough data so that I can show that this intervention that I'm training you in actually has the outcomes that I'm expecting. I also want to be able to identify the impact of the strategies on individuals, families, communities, and society as a whole. That's what I want to get out of this. Remember, I'm training you in this room. You're checking your watch because you've got clients in a minute. And I want to be able to identify the total impact of this intervention. I want to be able to translate that evidence into interventions and services that can be implemented in an agency setting. Okay, so I want to try this intervention. I want to measure its impact on a whole bunch of different kinds of populations. And then I want to be able to take it, write down how I did it, and turn it into something that you can use in your agency and I can now come and train you on. And then, of course, I want to educate everybody and train everybody and make sure that we then have a committed and trained workforce who's competent in delivering these evidence-based services. Well, this begins to fall apart in real life. First of all, producing this research that can empirically demonstrate what strategies works means we got to have enough cases in that agency that meet the criteria for the intervention. And that almost is never there as a researcher. You want to be able to identify the impact on individuals. Well, mostly you'll be lucky if, you know how people are, they drop out, things happen. So it's never perfect. You're never going to get as much information as you want. And then translating that into some kind of a program or an intervention that can actually be replicated in an agency, that's difficult as well, because, and here's where you also come in. When I'm trained in an intervention, you will automatically take that intervention, be all happy you got it, and then you will go and use it to do the job you think you're supposed to be doing. Not necessarily what was designed for that intervention to be doing. So for example, I'm trained in, let me pick something. Okay, CBT, because I can't think of anything else. I'm trained in CBT. It's supposed to be used on a certain population, but the child that I'm seeing today isn't part of that population. But I know if I modify what I'm doing to fit the needs of that child in that setting, I probably can get some good results. So I go ahead and I do it. Now, and I change it just a little bit because I have to, because of the setting and the age of the child and the needs of that child is a little bit different than what I was taught. So I change it, I twist it, because my job is to get to X, not to get to Y. And that's evidence-based practice. That's what you're supposed to do. If you're a clinician or a case manager or a direct care worker or a nurse or whoever's working with a client or a consumer in the field. You have to twist in order to accomplish what you need to do. And once you've done that, you've just wrecked everything. Because now we don't have fidelity to the model. We have individual decision-making happening on the job. What a horrible thing. So this nice model that researchers have laid out to try and solve some of these things doesn't work the way we want it to very often. We'd like it to, but it doesn't. Okay, let's talk about some of the other barriers that we have to developing these evidence-based treatments. In the mental health agency settings, we don't really like randomized controlled trials very much. We like everybody to get the good treatment, right? If somebody's got a silver bullet for some kind of a problem, we don't want to just give some people the usual kind of treatment. We all want to use the silver bullet. It's not fair. These are 6-year-old children. We want them all to get what we think is the best. So to actually do these randomized controlled interventions in an agency setting are very difficult to do. If you've got some other treatment that used to be the gold standard, and you want to continue to use that and then bring in a twist and put them in 2 different groups, sometimes that's easier to actually for people to stomach and do. But it's difficult to get agencies, and I mean, we all, those of us who are social workers have, and I think psychologists and anybody working in this arena has codes of ethics that we follow, and denying people service is one of those parts of our code that we don't want to ignore. So it's difficult to get these things done in that kind of a setting. Evidence-based treatments, the training is also very difficult to get done in the real world of an agency. Is there anybody in here who's in the PMTO evidence? Yeah, I got one person over there. And anybody else? Ah, there we go, another person. For people to get trained in parent management training Oregon model, the agencies have to commit to a bunch of different fun video equipment and managing that and making sure it runs and it works. And then they also have to have lower caseloads for the PMTO therapist. They also have to help them find the cases that meet the criteria. And even though we're very committed to that model, it takes some effort for agencies to be able to accomplish that. So sometimes productivity can become an issue, but also the infrastructure isn't there. If you don't have somebody who can fix the video camera when it breaks down, there's a problem. If you don't have the information structure in place that can allow you to collect information on consumers that can add to the ability to do the assessment of whether or not you have the right group of kids, that's a problem. If you don't have the ability to assess because you don't have the kind of computer size or you don't have the ability to use assessment instruments that need to be used in this, that's a problem too. So these are all issues that come up every time we try to do this evidence-based training, evidence-based treatment training. And so to you folks out there, what this looks like is, oh shoot, here we go. We got training for CBT. We all have to go to it. I'm going to have to put these clients off. That means I'm going to have to do this and this. It's really a pain. It's a bigger pain for your agency in some respects to try to support your getting the training that will make your ability to interact with your clients and to have outcomes that you want to have a better to happen, actually to happen. So it's hard for agencies. I know that you probably don't even want to know this, but it's very difficult for your agency to support these things. It costs money. It really is something that takes some effort. And then what I talked about before, the implementation, the fidelity to the model is always difficult to actually make sure that it's actually happening, because people will do what they think they need to do with the information they're given. And so that fidelity testing is an important part of what you're doing, and yet it's difficult sometimes to make it happen. I've been in a situation with, well, I won't tell you what system. It was not the CMH system. But oftentimes, people are trained in evidence-based treatments, and then because of budget cuts and other things that happen, they have to water the model down, but they're still showing that they're doing the model. That often is a problem for agencies, especially in these times, that you're going to be pushed to stretch beyond what the model that you've been trained in requires you to do, because there's no other way to get around the fact that we don't have the money to support the fidelity. Maybe a good example, since this is children's EBTs that we're talking about, I'll choose one from the adult world. Dialectical behavioral therapy, DBT, is a good example of that. There's a very strict model that needs to be followed, and caseloads need to be at 20 in order for the DBT therapist to have the time to be able to interact with consumers the way they need to. And it's very difficult to keep that caseload at 20 when agencies are really being pushed in terms of money. Okay, so this is, these are the realities you need to know about too, so that's where I'm going with this, but let's see here. The other thing about training that you need to know about, I guess, there is a push right now for universities to do some of this EBT training instead of leaving it for agencies to do after you get out there. But that's really very difficult for them to do, because universities, in case you haven't noticed, are about 20 years behind in terms of the newest innovations and what they teach. They have to have like 4 committees to decide on changing the curriculum, and it takes them about 2 years of studying it before the changes can be made. And by the time they've put that in place, somebody's found a different model that works just as well or better, and have moved on. So, and the other thing is, in schools of social work, MSW students are not there long enough to get the amount of training that they need. They move on through pretty quickly. So it's very difficult for that training to be done anywhere except once you get out in the field. So that's part of an issue too that we'll just mention. Okay, so why should we do it? Why should we do this to begin with? We already do it. You do it automatically anyway. Let's just get more formal about it. It's required by the funders. People want to know that they're getting something for their money. They want to make sure, and they should. They want to know that what they're paying for is actually happening. And one of the only ways that you can do that is to measure whether or not outcomes have happened. And if you're going to measure whether outcomes have happened, you're also going to want to know what is it that makes those outcomes better. And once that is known, you're going to want to train people so that they can get there. And it costs money to train people. As an agency, as a system, as a county, as a state, all of that training actually requires a lot of fiscal effort. So you want to make sure that you end up getting the results you want to. The training in evidence-based interventions also makes you a better practitioner. Even if you don't use it exactly the way it was intended. Of course you will for the specific population it was trained on, but as you adapt it for the rest of your practice, it makes you a better practitioner. How can it help but make you a better practitioner? It's new information. It's a theory of change that somebody's tested and found out to work. Why wouldn't you want to know it? It makes you a more valuable employee because you have training, and I can count on the fact that I'm going to get results that are important when you're in the field doing this work. And put on the bottom deliberately, it actually makes a difference in outcomes for the people that we're supposed to be working with. So those are all important reasons why we need to use these things and to be able to get the training that we need in them, and why you want to support this no matter what. I want to talk for a minute or so about what are some of these evidence-based treatments and how can they play a role in what you're doing. What are people being trained in now? What are some of the pieces that are coming down the road here that we might want to be looking at? All right, so I've got two people in here who have PMTO, who are involved in the PMTO mix. What about anybody in here who's got some experience with family psychoed? I know that's an adult intervention, but there are some people who were trained in that, I think. Maybe not. Maybe that hasn't happened anywhere. Somebody's trying to raise their hand? No, not really? Okay. What about CBT? Anybody have formal training in CBT? Okay, nobody's got that. Uh-oh. What? Somebody. Tracy says somebody. Okay, thank you. What about, we have any people with infant mental health certification? We got parent-infant program people there? Yep, okay. I don't think that's been recognized as an evidence-based treatment yet, but it certainly has evidence in terms of its impact, and it is being studied. I don't think SAMHSA has stamped it with its stamp yet, but it's working its way up the chain. What am I missing? Who else? Anybody got specialized training that they've taken that they're willing to share? Bunch of, what? DBT for adults more, it's used for adults more than it is. And adolescents, right. Yep. I think we're beginning to see that adolescents that we're working with, it's not this, when they turn 18, then they are eligible for DBT. There might be some overlap, yeah. I think we're starting to see, I know we're seeing that with family psychoed. There's Starfish, for example, has a grant that they're using to use it with their younger populations, their adolescents. And there's a push in the Wayne County to try it, to expand that out into other agencies to see whether or not it has an impact on adolescents. Anybody got any other kind of training? Yeah. Say that again. Solution focused. What does that involve? A brief therapy for adolescents. So a brief intervention to get them stable and then move on. Okay. Anybody else got anything special that they've been trained in? Gentle teaching, I've heard of that one too. Yeah, gentle teaching. Those are they're approaches, aren't they? With kind of an understanding of how to approach a client and then go forward with them. Okay, so you're all ripe. You're all ripe for some kind of training in your, I'm going to get a list of your agencies, and we're going to send people out tomorrow and start the training process. Another best practice that people are looking at in Wayne County is trauma-focused CBT. Have any of you heard of that? It's in your packet. I gave you kind of a description. You can That one actually is training that the county is going to do, and it's actually training that can be done online, but the county's going to invest in helping people to get some additional support besides what gets done online, so that we can train people across the county in that method. And it was developed primarily for children who were sexually abused, but it's since been expanded for lots of different kinds of traumas. And it's an evidence-based practice, oops, see what I did? That was with a small p. Evidence-based treatment that's recognized by SAMHSA. That means it's been in some of these randomized controlled trials. And that one, as I said, you can actually go online tomorrow and get yourself trained in that. Yes? Oh, SAMHSA. Sorry. See, there's that language again, right? I'm speaking a different language. SAMHSA stands for, let's see if I can get this. I can't do the S. What's the S? Substance abuse, mental health, service administration. Yes, that's it. It has a website. And if you go to the SAMHSA website, it's listed in your packet again too. If you go there to the website, there's a whole discussion on evidence-based practice, evidence-based treatments. SAMHSA has toolkits that are available for use in putting some of these evidence-based treatments into play. So, a lot of them are adult-focused, but for example, supported employment is a toolkit that you can get from SAMHSA to begin to put supported employment in place in your agency and working with adults. There's a lot of different, they've got about 6 of them, I think. I was going to try to go to their site, but I don't think we have connectivity to the web. Yes? She wants to know if there's any kind of evidence-based treatments that specifically can aid you in working with foster care children or kids in foster care, I guess. You know, you have to think about what it is that you're really talking about when you're talking about kids like that. I think what you're talking about is utilizing evidence-based treatments that have been tested on populations who have certain characteristics. So, for example, depending on the age of the child, if they're infants, 0 to 3, the infant mental health model developed by the Michigan Association of Infant Mental Health, that would be something that you could use working with that population because it's all about attachment and those kinds of issues that are going to come up for foster children. Okay, so there's that. If you're talking about mental health, kids in foster care have the same characteristics when they have a mental illness that kids in other populations have, but they also have the added impact of being in foster care and maybe the trauma that was suffered as a result of the abuse or the neglect that they experienced. So again, I think you have to look at what are some of these interventions that we're talking about, and do they match the characteristics of foster care kids? There are treatments for treatment foster care is one of the treatments that I think is out there that's being used by DHS now. It's a way of working with certain foster parents in homes and providing certain kinds of behavioral interventions to try to help keep the kids stable. I see your hand, so go ahead. He's asking about a policy that's at RESA, the Regional, say it again, Education Service Agency, RESA. They dictate for Detroit Public School who gets what kinds of treatment, and they're saying that kids who have maladjustment disorders do not, do not qualify for special ed. And he's asking what treatments are out there for kids like that. You know, I don't have any off the top of my head, but I would urge you, when you're doing this evidence-based, looking for evidence-based interventions, what you're looking for is, what are the problems? Again, remember, that's how this works. You take what it is you're trying to solve and turn it into the problem. So you have kids with certain behaviors. Okay, ODD is one of the behaviors. So if I have a child with ODD, what is going on out there in the way of interventions for kids with ODD? That's your question, and you're not looking for kids who, so you're looking at the specific characteristics of conduct disorder. They don't qualify for special ed, but their behaviors. I would think if it's not a mental health-based problem, and I think there's some iffiness in terms of, depends whether or not they've had a diagnosis, right? Or whether or not it's a behavior-based issue. There are certainly evidence-based treatments out there that focus on kids' behaviors and how to manage them, okay? And that's what I think you're looking for. Oh, now he's telling me his real problem is how to get the schools to implement them. Well, that's a whole, you have to go back to school and become a community organizer. That would be the answer to that problem. So you don't really want an evidence-based treatment. Okay, well, we can look up together a treatment, but I can't make the schools do anything. I've tried, it doesn't work. They got their own way of doing it, and so I'm kind of kidding. But we can talk, I think evidence-based practice, actually, now that you're saying that, if you find a solution for that you think would work in a school, I would urge you to try to get it into one school where maybe you've got an opening, try it out, right? That's what evidence-based practice is. You find a solution to a problem, try it out, take that evidence to the next person, get them to try it, and now you're building a movement. People who do policy change, you just touched on one of my great loves, policy change. People who do policy change, it can happen in two levels. It can either happen from the top down, right? The president says do this and we do it, but most of the time it happens from the ground up. And when you get a critical mass, you get enough schools in Wayne County using this, then RISA will go, oh, look at that, what a good idea. And it was ours, by the way, so now we're going to put it in play. That's how it works, one school at a time. But first you need to find something and somebody's doing it somewhere. Somebody's got something they're doing in the schools to work with kids who have that problem. You just need to find it, look at it, see if it would work where you want it to, convince somebody to try it, and then take your evidence and show it to others and grow it. That's so simple. I don't know why you haven't done it yet. Tracy, I saw your hand and now you're talking, so maybe you don't want to talk.
I know just enough about this to be dangerous, more or less. But
Can you all hear her, or do I need to give her a mic? Give her a mic. There we go.
it is on. Okay. RISA is moving towards a program that's called RTI, which I believe is retention treatment intervention or something close to that. And what the schools are doing is they're asking that we not immediately ask for testing or IQ or have our psychiatrist require the schools to put these children through testing. What they want to do is put them through this RTI program and work their model, and it's a specific model and you can get the information from RISA. And then if that doesn't work, then they want to move towards the mental health intervention. We can, work with one another while this is going on, but they want to take that approach first.
So so the reason Tracy knows about this is because she's got kids who are in a home-based program who are having trouble in school with ODD. They've been seen, but they also have mental health problems, and so she's been talking to RISA about this. So that's a start. So maybe the two of you could speak afterwards, and she can explain a little bit more about where you can get the information. Okay, so We don't have a lot of actual certified training in this room, but we have people who have probably taken, you've gone to grand rounds, you talked to your coworkers, you've gone to workshops and presentations, you've gathered information, you're sitting in your office with your door closed like Kevin, reading things so that you can give me stuff and make me think that I have to do something about it. That is how you're practicing right now. And what I'm suggesting to you is there are trainings out there that give you certification in these evidence-based interventions. And if you've got a problem, the first step in all of this is identifying the problem that you don't have a solution for, a pattern that you've seen in your caseload, a change in what's going on. You've been working in the field for 10 years with a certain group of kids who have certain kinds of characteristics, and you're seeing a difference in what's going on with them, a change in the pattern, a new problem that's coming up. And you want to look out there and see what others are doing so that you can try and find out what you might do about it. That's what evidence-based practice is really all about. That's how it really works. Okay, I need more questions here. I never have a problem talking for like 3 hours, so you didn't interrupt me enough. That's what's going on here. What other interventions are out there on the horizon that we need to be getting ready for? You know, Wayne State University did a study. They surveyed all of the agencies across Wayne County to determine whether or not we were ready for evidence-based practice. And they found that in agencies where the administrators believed in it and were ready to support it, that those agencies had more clinicians who were also ready and willing to take on the training that was needed. So that's another piece of this. If your colleagues are also interested in these additional trainings, then that can happen as well. Yes? Family psychoeducational model. She wants me to talk more about that. There's an explanation of that in your packet, but basically, what's happening there, I think, when McFarland, who's one of the original designers of this, came to Wayne County and spoke to a number of us, he was very clear that what and here's another thing about these evidence-based treatments, if you can take this away with you as well. There's a theory of change. They all start with this theory about what's going to happen if you do some particular kind of intervention. And then they test that theory. Does it work? And who does it work with best? And what are the things we can expect to happen if it's done this way? And what McFarland says, I mean, all that he's trying to do, he and his colleagues are trying to do with this model, they're recognizing that one of the areas with particularly adults, which is the group that they first looked at, who are persistently mentally ill over long periods of time, is that they and their families get on each other's nerves, right? The families, you know, they recognize the behaviors are going to come up again and again and again, and the adults who are living there or who are in contact with their families are annoyed by all kinds of things the family members do to try to make them be safe. And so what this is an attempt to bring the family and the consumers together in a group of other families and consumers. That's how the model was originally planned for, to discuss these annoying things that happen between each other and how to deal with them, how to cope with each other, how to understand what they are, to get some understanding of each other's position and to work through this annoyance into more of an acceptance and support. And so the translating of this to teenagers who are getting ready to transfer into the adult system, kids who have disorders that are going to go on for the rest of their lives, or for a long period anyway. It's to do that early in the process, when they're still teenagers, Because what happens when teenagers move into the adult system often? They stop treatment because they can. No parent now can make them come, right? So what we're trying to do is, what this is trying to do is to set up a way to make that support be present for those teenagers so that when they do move into the adult system, we've got the support set up and the interaction with their family already present. Because a lot of times we lose them for a while, right? They kind of disappear off our radar until they show back up later. And we're not just talking about 17-year-olds, we're talking about 14, 13-year-olds, doing this with families at an early age so that we can interrupt that cycle of annoyance, for want of a better term. So is that enough information about that? And what we're hoping to do is, not hoping, is to do training in the model, train the trainer kinds of things so that people can get trained over time and we'll be able to use it and integrate it into our practice. It won't be a specialty over here that you get referred to, so that we can use it as we need to. Go ahead. Yes, that's what he said. I'm sorry, I didn't finish my story. There was McFarland talking to this meeting. I'm sitting there eager, and he got asked the question, can you use it with teenagers? He said, why not? Yes, you can. As long as you can, I mean, you got to look at the theory. What he's saying is this is a chance for families and the child or adolescent or adult to work. I mean, you're going to have, an 8-year-old is going to have a different ability to discuss these things than a 16-year-old. So yes, but it's absolutely adaptable. If you buy his book, you can see it. It's not, I mean, he's the first one to admit this isn't rocket science. It's really just developing a way for, it's helping to teach parents and their kids how to talk to each other and work through problems. One more, go ahead. Oh, what an excellent question. And she said it just in the nick of time. What she asked me was, how far can you go in taking these evidence-based treatments and adapting them and still be using an evidence-based practice? Here's the catch. What you don't want to do is take what you learned, go in that room, and close that door again. Whenever you take an evidence-based practice and you want to twist it, and try it out on a 6-year-old instead of an 18-year-old. What you've done is there's a body of knowledge about those 18-year-olds and how it works. So you want to follow the model, try it with 8-year-olds, compare your results. And then you'll have something to add to everybody else's body of knowledge. You'll be able to raise your hand and say, I tried it on 8-year-olds, here's exactly what I did, and here's the results I got. And if you're smart, you'll go to your local university or to somebody and get some help from an evaluator to come in and help you set this up so that you're not just operating out there in the wind. And I'll tell you, if you really wanted to do this, you could actually email McFarland, who actually is helping Starfish to try it out with this different population, because there's nothing more than the inventor of an intervention, nothing more than that person wants, but to expand their field, right? To take their intervention and try it on a different population. So you would probably get some support on some level for making it happen. As long as you are documenting what you're doing and measuring the outcomes, you can adapt it however you want to. On the other hand, you can also do it if nobody is requesting that there be fidelity to the model, if like CBT, most people don't, if you're trained in cognitive behavioral therapy, there is you learn to use it, there's a practice of doing it, but there really isn't any kind of fidelity that anybody's measuring in terms of how well you're doing it or what you're saying when you're actually doing it, right? Anybody even know about CBT? I'm sure you do, to some extent. Okay. 1958, when it was invented. Yes, it was. So psychotherapy kind of choice and option here. But you're supposed to take it and personalize it. That's its point, okay? So you have to take that into account. So with something like that, you're just going to use it and you're going to tweak it to fit who you are in the situation you're in, and that's perfectly fine too. So if you use McFarland's model, basically, and you try it on a different age group, and you're just doing it, and you're getting the outcomes you want, there's nothing wrong with that, okay? It's in his book. You can take whatever you read and use it. That's in the public domain, okay? And yes, ma'am. Oh, I don't know. I think it's got psychoeducation in its title. I have a copy. But McFarland, M-C-F-A-R-L-A-N-D, it's in your packet. His name's in your packet. And if you actually just look him up online, you'll get a bunch of hits that will give you an overview of what it is. Trauma-focused CBT is the same thing. If you type in TF-CBT into Google, it takes you right to the website. Anybody else? Yes. Agencies, you can take your ideas in Michigan that use the evidence-based or support it. Well, I don't know any agency that wouldn't support it if they thought that it was going to make their interventions more effective and more efficient. I think anybody would. I mean, Kevin was a pain in my rear end when he brought it to me, but it turned out he was right. Oh, how complicated it is to do it, so why would they do it? Well, you know, it's interesting. When the funding stream says they want you to do it, you find a way to do it. And at our agency, in addition to that, if you bring me something that is going to eventually down the road be, I mean, it's called cost effectiveness, right? So putting the money in at the front end and paying the price and the pain of doing the training results in good outcomes at the other end in terms of efficiency and effectiveness. And that's the argument that you're going to make, that this is going to have a cost benefit to it. It will cost up front, but the benefit in the long run of other people who have done this is huge. And then I'm going to buy it because it makes perfect sense. I think that one way, the argument that always trumps every other argument is fiscal. That in the long, you know, if you can put something in play and I'm going to be able to measure the results and I'm going to be able to see its impact and it's going to be a positive one, then I'm going to buy it and find a way to do it. So I think just about any agency is going to be looking for ways to maximize their interventions and to be able to be as efficient and as effective as they can be. At least, maybe I'm naive, but I think that's true. Yes? JJDRA. Juvenile Justice. Oh, Delinquency Reintegration Act? Or is that what it is? Boy, he's talking about something that was around when DSWs were around, delinquency social workers. That must have been in the 60s.
No, that was back in the 90s.
Oh, the 90s, the 90s. I don't know anything about that, but I would imagine if you went to the website of the Office of Juvenile Justice and Delinquency Prevention, OJJDP, you might find something about it in there, because they have, you know, most of the major federal agencies that provide funding for some of these evidence-based treatments, they have websites. And on those websites, they have the ability for you to look up research. And you just type in keywords, and they have research that they have funded there on the websites. So almost anything you can think of, you can find on the web. I will tell you one of my pet peeves about research and practice has to do with access to information in general. All of the academics I know who work at universities can go online, type in their password, and get access to their libraries, where they have all the journals sitting there on shelves in cyberspace. And they can go in there and they can access all these journals that have published all these papers on all this research that's been done out there. And you can't get them. You can only get what's in the public domain floating around out there on the web. And to me, that's one of the biggest holes in your ability to become good evidence-based practitioners, because you really can't get at everything that's been done by these research folks unless you have access to their library. You can get a lot of it now, a lot more than you used to be able to, but you still can't get, and since I have a password, I have more than you. I have power, that means. I'm sorry? A graduate student can access it, and the good news about universities is, it usually takes them about a year to know you've graduated, so you can also get in there for about a year afterwards. It took them like 5 to know I had, so you can apply for the alumni, but it still costs money, and you have to do that on a personal basis. I looked into how much it would cost our agency to do something like that, and it was a lot more money than we were willing to pay. So we just use my password. Everyone has it. Don't tell U of M I said that. Because it's very expensive for them to run that. Anybody else? Okay, well, I made it to 11:30, so that's the good news. If there aren't any more questions, I'm finished. Okay, thanks.